Okay, guys, I think we're going to begin. So, welcome everybody. I have tried something new during this talk and I've untethered myself from the podium. So I'm going to be doing a lot of pacing back and forth. I hope that doesn't distract anybody. It is in an effort to keep you more engaged. There is a little eye at the bottom left-hand side of the corner, so somebody is watching. I don't know who it is, if it's other physicians, the OMA, the Ministry of Health, but hopefully we'll get through this talk and I will remain a resident and employed in this province. So, my name's Shawn, I'm one of the R5s, and I thought this was a very topical thing to be discussing at this time. This week has been a very busy week on this front, and before we get into it, I want to say a few thank yous. So the first thank you is to my supervisor, Dr. Jeff Freeman, who took a lot of time after a night shift to sit and discuss the issues, but who also recently quoted Thoreau in an email to me that critiqued my presentation, so that's always cool. Dr. Atul Kapoor, who was kind enough to review the entire presentation and provide me with some feedback, and who's also our kind of resident expert on the negotiations and the OMA. Dr. Taylor Lougheed, who in his kindness sat down with me at very last minute yesterday to discuss some elements of the presentation. And last but definitely not least is the Facebook group. So by the laughs in the room, I clearly know that many have been watching and seeing what's been going on. The Facebook group that has to do with this has clearly affirmed to me that this talk is necessary and that as a group of physicians, we need to know a little bit more about this whole process. So, this is a smattering of headlines that have appeared in the last 9 months. Some of them are enraging, some of them are supportive. Regardless, you can find an article to support whatever position you might have out there in the media right now. These are the Facebook groups. Okay, so the top one that you see there is what we're calling We Are Your Ontario Doctors. This is a community of physicians. This is a public page of all of the physicians in Ontario that have gotten together. And it's a platform to communicate a message about the cuts and their effects on patient care. The bottom group is Ontario MDs concerned about continued funding cuts, which is a very different title than the top one. That group is a secret group. What's notable about that group is that it includes about 11,000 physicians in this province. That's actually a very impressive number. And it's a forum where physicians are sharing ideas about how they can approach messaging to the government outside of the OMA about this continued funding cuts that are going on. There's a lot of interesting rhetoric that has happened there, and that's all I will say about the group for the moment. So when I heard about the cuts, I kind of felt like I should feel like this. I kind of felt like I should be upset. I know a lot of my colleagues were. But truthfully, this picture probably summates how I felt the best. I had no idea what the context was for ongoing cuts. I had no idea why they might be happening. And so I thought to myself, well, it's probably worth looking into. And I'm sure I'm not the only person that feels this way. Ultimately, the question was, what am I missing? It's like you're in urgent care and you're missing that scaphoid. You're left with that weird, uneasy feeling when you make that judgment and send that patient home. Or like that 85-year-old who gets in an MBC and your only diagnosis is fractured humerus and you miss his trifascicular block. Or, more importantly, and maybe more topically in my household, it's like labeling Elsa a villain. When in fact, the complexity of the New Age Disney classic is underappreciated if you do that. So let me help you with some understanding. We are going to cover, why does the Ministry of Health want to cut our wages? What do physicians' wages look like in Ontario? What led to this whole fiasco with the OMA and Ministry of Health anyway? And what's likely to be the next steps moving forward? Okay, Why would they want to cut MD salaries? So let's look at the following for some understanding. Are healthcare expenditures on the rise in Ontario? Does Ontario have a large debt? And will Ontario have less to spend on healthcare in the years to come? Those seem like reasonable questions to ask when you look at a province who's spending money on physician services. So, this is how the health budget has evolved over the course of the last 8 years as a percentage of the total budget of Ontario. As you can see, between 2007 and 2010, there's a dip. But since 2011, it's pretty stable. I've included education there to show you the trend relative to another budget item in the Ontario budget, but also to show you the difference between what we pay to educate our children and what we pay for healthcare. But when you look at what we actually spend versus what we budget, there's a difference. There's about a 5% difference. And 5% in most things isn't that big a deal, but when you're budgeting in billions, it kind of is. Everybody get that? Okay, nods. So the next question is, well, what about our provincial deficit? Are we like in a ton of debt? Like, do we have no money to spend? Maybe that's why we're really trying to cut back on our expenses right now. So if you look at the debt in red, which is a great color for debt, and you look at the green, which is our health budget, you can see that after 2009, suddenly our province starts to accumulate a ton more debt. Does anybody know what happened in 2009? Anybody who has a portfolio, an investment portfolio, might be able to tell you. All right, so this is the 2009 recession, okay? And our government, in response to this, spent money to stimulate our infrastructure sector to increase the economy's GDP in Ontario. Now, whether you believe this is the appropriate approach or not, every single government in Canada did exactly the same thing, including the federal government. This is not a party thing. This is the approach the large majority of our country took in response to the 2009 recession. Okay. So, let's talk about increases in spending. When you look at how much debt was accumulated year after year compared to how much the health budget changed year after year, you see this massive peak in 2010. What that peak means in this graph is that between 2010 and 2009, we acquired a ton more debt all of a sudden. The reason I made this graph is to show you how much of that percentage might have gone into healthcare as part of stimulus spending. And as you can see, the bar in that year does go up relative to the previous year, but not a ton. So we might be able to infer from this that yes, we spent money to increase our economy, but a very mild stimulus effect was likely felt in healthcare. So we were probably spending money elsewhere, which is likely okay. That's what everybody else did as well. The next question we need to ask ourselves is there less money in healthcare moving forward? This begs the question, where does the provincial government get money for healthcare in the first place? So some of it comes from our provincial revenues, all the taxes we all pay on everything that we buy or purchase, municipal taxes, all this, everything that we pay on a daily basis that goes into the provincial coffers. But that's not all of the healthcare costs. That's not all of the healthcare budget in this province. So what about the remainder? So I'm going to break this down for you in the most simple way that I can do it. I'm going to try to explain to you how the federal government has a proportion of the costs and how that's changing in the future. So let's start with the fundamentals. The Ministry of Health pays for all of healthcare costs in Ontario. That's a pretty straightforward point. Everybody get that? Blank stares. Moving forward. The Canada Health Act formalizes how healthcare happens in this country. But that's a federal act, so things start to get muddy all of a sudden. And some of the money that pays for healthcare in Ontario comes from the federal government. Then ultimately the question is, who actually pays? So 1984 was a big year. And I know that dates me in the eyes of some, and I'm Sorry for the older individuals in the crowd, but that's what I'm going to say. 1984 was a big year. That's me in my hometown of Elliott Lake shoveling snow, which happens about 10 months a year up there. But it's also the year that Tommy Douglas passed the Canada Health Act federally. And it's the year that the Canada Health Act took effect. What is the Canada Health Act? The Coles Notes is this. The Fed said, if you do all of these things as a minimum requirement of a healthcare system, and then there are like 6 chapters of conditions, we will give you money to fund healthcare in your province. Now, the proportion of that they were going to fund initially was much higher than it is now, but regardless, the conditions stay the same. So how much money are they actually giving us? Well, in 2014-15, we're looking at $19.2 billion, which is a 35% share of our public spending of healthcare in this province. That's a staggering amount of money, actually. So when you look at the federal health support that we get in Ontario over the course of the years, it is on the rise, but it's also generally in keeping with inflation, which you see in the red bars there. So we are getting more money, but it's money that's keeping up with the value of $1 year after year. Okay. So are transfers changing? Well, funny you should ask. And there's clearly a reason why I brought this into the talk. So in 2011, the Conservative government announced that they were cutting the federal health transfer. So all the provinces got together and they made kind of a forecasting document on what this would look like for every province. The new funding formula from the federal Conservative government means that starting in 2017-18, the health transfer will mirror a 3-year average GDP growth, with funding guaranteed to increase by 3% each year. So in order for us to understand the significance of that, we need to know what we're at now. So basically, the government told us year after year, we'll allow that to increase by 6%. That is what we're committing to year, a 6% increase in the federal health transfers from the federal government to the provincial government. But in 2011, they said, you know what, we're going to change that. We're going to look at how our economy is growing. We're going to take a 3-year average, and we're only going to increase it by that amount to a minimum of 3%. So if it's any less than 3%, you're going to get 3%. But we're definitely not committing to 6% moving forward. So the question then becomes, well, how much less are we going to have in the years moving forward? So this is a graph that was made by some important stakeholders that I think in this whole argument. So the Parliamentary Budget Officer, the Canadian Institute for Health Innovation, and StatsCan, who I think are probably reputable people to be making such a graph. The craziness about this graph is that it goes out to 2087. So I'm not a huge fan of predictions in the first place. Predictions that are like, 60 years out are a little bit odd to me. That being said, clearly the trend here is that we're going to be getting less money to fund healthcare in this province from the federal government. This is a Canadian-based graph. So what will this look like in Ontario? So the blue is what a 6% increase might look like year after year. The red graphs are what we're predicted to get. Now, the deltas aren't that big there. And so people might wonder, well, that doesn't really look that bad. So let's break this down into percentages then. So at 2023-24, we're going to be getting 15% less than we do now, or than we should have been getting at that time. And so ultimately the question is, 15% of a several billion-dollar budget is actually a lot of money. And where are we going to make up that difference? How are we going to pay for those things? So a summary of the provincial government side of things is that every year we are over budget in our health budget. We ran a deficit in 2009 in response to the recession, which everybody else did as well. But now we have to recoup those costs somehow. And starting in 2017-18, we're going to be getting way less money from the federal government to pay for health care. So we're going to play a little game. This is how, in our country, healthcare costs are broken down. These are the 3 big spends in the healthcare budget. I'm going to allow you guys I was going to initially divide you by column, but you guys are kind of underrepresented. You're strong, though. You know what? I'm going to keep you that way. You're strong. Okay. So I'm going to give you guys 2 minutes. And in this group, I'm going to give you the hospital's responsibility. I'll give you guys the pharma responsibility up there. Dr. Pharma. Okay? Dr. Freeman's smiling. And this group, I'm going to give the physician's responsibility. So I just kind of want you to coalesce with the 3 or 4 people around you and answer this question. So if you had to reduce costs within your portfolio, how would you do that? I want to spend 2 minutes. Give me some ideas. We're going to give 1 or 2 bullet points, and then we're going to come back here and hear everybody out. All right, bring your arguments to a close. Bring your arguments to a close. Okay, all right, let's do this. So, I'm just going to solicit openly from this group. Just shout them out. So, how would you control hospital costs? Okay, cut the CEO salary. All right, go to the C-suite, get all your savings from there. Okay, good. Anything else? Cut the meet and greets. Okay, well, that's interesting. Anything else from this group? Okay, good. Dr. Sorry, say that again? Care maps and accountability. Care maps. Okay, good. I like that. Okay, all right. Lots of management stuff. That's great. Okay, good. Right.
So the tiniest cuts, if you're doing multiple things like that, you can make a big difference.
Right.
One of my pet peeve is why can we not just swipe the patients in at the front desk and emerge, for instance? Can that not be automated instead of having to wait for charts all the time?
Right. So there's a few points there. Look to some technology for savings and to increase our efficiencies overall, so we get small savings on many items that we do several times, so that our overall savings are better. Okay. Before I get to you guys, before we talk about doctors, I'm going to ask the pharma group. So how would you save money based on drug costs?
We need to know where the costs are so we can figure out where to save. We don't have the data.
Okay, well, come on.
No, but it's true. I mean, part of the problem is we would, if we knew what the cost of an antibiotic was,
Okay.
between two,
Right.
similar efficacy,
Oh.
cheaper. We just don't have the data.
So what you're saying is provide the front-end user with some data so that they can make some cost choices. Right, okay. Well, that's an interesting way to look at how pharma might affect overall spending. Anything else?
You can do the same, make the same
Right. Okay, so there needs to be a clear benefit that outweighs the cost of an additional drug therapy. Okay, anything else?
Well, we need a global, probably national drug purchasing group.
Right, so there's a lot of nods in the room for that. So the national pharma strategy is something that's thrown out a lot, and a lot of people have talked about, but the kind of bulk purchasing power of pharmaceuticals to get kind of a premium decrease on our individual agents. Okay, anything else that needs to be mentioned before we move along to this group? Okay, somebody wants to talk about pharma in the physician group. Yeah?
Canada has the highest generic drug costs in the world.
Mm-hmm.
And so if there's any federal regulations on drug companies that could help prevent excessive generic drug costs, that should be pursued.
Yeah, that might help. I agree. Okay, a minute or two to spend on some physician ideas. So how would you cut costs on physician, in the physician part of that budget? Okay, well, that's a novel idea. Cut physician salaries. That I'm not going to say who said that. Who else wants to chime in on this one? George.
We were discussing that we need to totally overhaul the way that physicians are remunerated in the fee schedule.
Okay, so people have critiqued the fee schedule. It's like an 800-page document that's very convoluted and difficult to navigate. So maybe looking at kind of an overall approach to how we remunerate physicians might be helpful. Anybody else?
I find there's a lot of consults that happen to other services when the service referring already knows the answer.
Mm.
And so it's kind of like well, we're just doing this because. But that consult comes with a $100 to $200 consultation fee.
Right.
So how many times does that happen in the hospital where, like as an example, you're calling ID to say, how long are we giving them antibiotics? But you know the answer is 4 weeks and then rescan them. So that kind of stuff.
Right. Okay. Anybody else with some?
The hospital, by the way, doesn't have access to what we have in the community, which is e-consults.
Right. Could be nice, eh?
What's that? E-consult is, if you have a question, if you have a question that you think you just want advice on, or it's more of a question you're not sure if this person actually needs to be seen, you can actually just email the question, and they will email you back the plan and the answer. So it saves all those consults that you're just wanting to do, like that.
We are presently working on this for the lab. Thank you.
Well, it has to be, it doesn't save a bit of time, but it saves consultants time, and then they can focus on the people that have cancer.
Yeah, complex patients. Okay, one last comment, and then we're going to move along. Mm. Right. Right, so there's kind of a duplication of consult when there's no expectation of involvement from certain consult groups. All right, one last thing.
I was just going to say about kind of utilization of allied health professionals such as nurse practitioners or physician assistants, and making the role of physician more specific and kind of utilizing the skill sets differently.
Right, so that's quite a common point that we're hearing when we're engaging in these discussions, and it's not a one that's without controversy either. So let's jump into physician income, salaries, wages, whatever you want to call it, and we'll get back to the negotiation process in a bit. Okay. So I initially started by calling this MD income, but then some people took exception to the term MD income, and so then we called it MD payments, but then also other people took exception to that. So then it was MD remuneration, and then other people thought, well, maybe that wasn't reflective of how we deal with the province, and so honestly, I've scrapped this all. And I'm essentially calling it where I got the data, and that's average provincial MD gross income as publicly reported by CAHAN. Okay? So there's some transparency here. You guys know exactly where I got the data, and this is average numbers, and you guys can find these numbers as well. Okay, so the key questions I asked were, are MD incomes in this on the rise in the province? I addressed the assertion of Minister Hoskins that we've had a 61% increase, and you'll see that that's not in fact the case. What are different specialties making? Interesting question. And do all specialties follow the same trend moving forward from in the last 10 years? Okay, so here are the trends. So in the purple line, you're seeing the total physician trend of all MDs in Ontario. The blue line are family physicians. The red line are medical specialties. The green line are surgical specialties. Now, I'm going to address the critique I'm going to get right now, that the y-axis does not start at 0, and that this is a pharma strategy to accentuate differences. The reason I'm doing this, it will become evident in 2 slides, okay? Truthfully, what you should notice here is that there are some differences in these trends, at least in the family physician area. They've been relatively stable over that course, without a ton of increases, at least on average in this province. Okay, so here's the famed statement by Dr. Hoskins. Ontario's doctors are already handsomely paid, with salaries that have risen 61% since 2003. I don't know about you guys, but that seems like a ridiculous amount. And so it was just too palatable to not dig into the data and try to sort out what actually the delta has been over the last 10, 12 years. Okay, so basically what I did is I looked at the data since 2003. I normalized the 2003 dollars into 2014 dollars, and I actually just looked at the difference. And the Bank of Canada has an easy online app that allows you to normalize dollars year to year. So this is actually what the increase has been in that time frame. So overall, all physicians have taken a 6.3% pay increase over that time. That's above inflation. What's notable here clearly is that family physicians have taken a pay cut since 2003. Not because there's been any strategic cuts in their fees, but because their fees have not increased proportionally to everybody else. Our surgical colleagues are making about a 9% overall increase in that time frame, and our medical specialties are making an almost 8% increase in that time frame. So GPs have actually taken a pay cut. It's nowhere near 61%, and on average it's about 6.3% for everybody. Okay? So incomes per physician group. So these are the medical specialties versus the average. So the average, you see that light pink line kind of in the middle. So some medical specialties are above the average, some medical specialties are below the average. The top earner there you're seeing as internal medicine, but that also includes procedural specialists like gastroenterologists. So we also know that those procedural specialists tend to make a little bit more money than non-procedural based specialists. That's not news to anybody. When we look at our surgical colleagues, this is the trend in the surgical group. You can see that a few surgical groups have taken a cut as of 2011, 2012 in response to some focused government cuts. And the kind of summary to be made from these slides is that income trends are relatively similar within surgical specialties and medical specialties, although there are some outliers. Okay? A lot of scrutinization going on. When we look at the other categories of costs that we talked about before, so there's some hospital costs or some pharma costs or some MD costs. Pharma and MD tend to kind of wax and wane over the course of the last 30, 40 years. Hospital costs are coming down. That's not purely because hospitals are becoming more efficient. It's also because we're decentralizing a lot of care that happens in hospitals, and we're just moving that cost out of hospitals. Hospitals also have the ability to cut procedures in people, and physicians don't have the ability to just see less patients. The one comment I'll make about our average increase in income over the last few years since 2003 is that assumes that we're seeing the same amount of patients, when in fact we might be seeing more patients, and that accounts totally for the difference rather than a pay increase. Okay. So I want to get into a quick discussion from the group here. We're going to do this for a few minutes, and I won't say your name when you say the comment, so that if this video is seen by anybody else, that you won't be named. But the question is, we seem to have a ton of difficulty in medicine to talk about the differences in income between specialties. It's like this thing that we really don't feel comfortable discussing. I posted some of these graphs on the Facebook group as kind of a water testing. And I have to tell you that within 24 hours, all of them were removed. by the administrators of the group. There was no interpretation that I had put on those images. I put up the images, I put up my source data, and that is all. That is all I put on the group, and they were removed. So the question is, why is this a politically loaded thing, and why can't we address this issue? Why can't we talk like grown-ups about this whole thing? So does anybody have any points to add on that question that I put to the crowd? Lots of hands. I love it. Okay, go ahead.
So it's been a contentious issue for my entire career.
Okay.
And this is not different. The costs are not different over the whole time.
Mm-hmm.
Okay? But whenever it's been approached and the OMA has tried to equalize things, then we've landed up with lawsuits from the people who are at the top of that graph against the OMA so that they cannot institute some kind of reorganization. Fee-for-service is partly the problem.
Right.
Because as soon as you can do something more efficiently, then you make a ton more money out of it, which is maybe a good thing, but it becomes a bit ridiculous with some of the things that go on.
Somebody sneezed over there, if nobody heard that. Okay. Go ahead in the back. Okay. Okay.
From a financial standpoint, it's one thing, but from a personal standpoint, I think it's taken out.
Okay, in the front.
In front. I do think one thing that needs to be considered is opportunity costs, and in the case of some specialists, particularly office-based ones, capital costs.
Mm-hmm.
And those have to be reflected in any number.
Yeah, and that is an argument. So there's some overhead that's associated with different specialties in addition that's different than other specialties. Attempts to appreciate the overhead have been made, at least through some self-reported studies, and those studies are available. I'm happy to disseminate those. But truthfully, there's no real objective measure of true overhead costs. It's always self-reported, and so you worry about bias in that data. Does anybody else have anything to contribute here? You don't need to put your neck out. Don't feel like you need to. Okay. So we're going to leave this for a moment, and let's get into the whole negotiations thing. And let me bring you up to date in the quickest way I know how on what is exactly going on in this province. Okay, so a quick note on negotiations. We do this every 4 years. This is like a masochistic process that we engage in with the Ministry of Health every 4 years, which is always really hard. We always labor really hard. The OMA tries as best they can to come to a contract that best represents physicians, but this is done quite frequently, actually. This is the time frame of the most recent ones, but something changed in 2012. The way we approached the contract changed in 2012. So let's look at the history of the big fee changes across the board, and then we'll get into some specific changes. So this chart shows us the big changes across the board changes that have occurred since 2009. Now, the first thing I'll have you note, this is really cool. I've been waiting to do this, actually. The first thing I'll have you note is these first 3 rows, okay? So in fact, in 2009, 2010, and 2011, there was a negotiated 3 consecutive year fee increase across the board to a total of 12.25%, okay? That's pretty notable, actually. And in all the discussions around the fee cuts overall, nobody's really mentioned this at all. But remember what we said earlier. The recession happened here. In the middle of where the government committed to spending more money on doctors, the economy was flushed down the drain. And when I talked to Atul about this, he said, we got by the skin of our teeth. He said, we signed this contract like 60 days before the economy started its downturn. And had it been 2 months later, this probably would not be a reality at all. All right. So then we get to the most recent ones that we all know about, which are these ones down here. Those are the ones that have happened this year and the source of all the physician outrage that you've been hearing about. So 2.65 decrease earlier this year and recently a 1.3 decrease. All right. This one we agreed to. the 0.5%, was something the OMA agreed to as part of its ongoing negotiation in 2012. All right, so let's move forward with this then. I'm going to do this in a line diagram so that we don't get bogged down in all the details. This is the sequence of events as they have gone down since 2012 as we were trying to negotiate a new contract. So, the OMA and ministry talks broke down when we were negotiating our 2012 contract. And the reason they did is because the government, in response to the breakdown, cut fees unilaterally in specific fee areas. And the OMA had no appetite for this at all. In addition to that, the ministry actually challenged the OMA's right to represent physicians solely in this province. And the OMA didn't really like that very much at all. And so what did the OMA do? Well, they launched a constitutional charter challenge in response to this. So they challenged the OMA's ability to, 1, unilaterally decide cuts, and 2, to lobby with anybody else outside the OMA because they were the single representative of physicians in the province. By every standard and critique of this move, it was thought that they would force both people back to the table, which is exactly what it did. The OMA kept the charter challenge alive despite being back at the table and negotiating. So in 2013, they agreed to a new contract that expired in 2014. But they also agreed to what they call the negotiations guide. So this was a playbook. It was how both parties needed to act in good faith to assure that they could come to appropriate resolution steps in the hope of coming to a finalized contract between the two groups. So let's do a quick side run outside of this and appreciate what the 2012 contract said and how it was different. So this contract basically included this 0.5 across the board cut. This is something the OMA agreed to. There were several cost-sparing measures that were planned. So basically what the government said in this contract is that, you know what, we don't have any money. So please agree to a small cut, and the OMA did. But then they also said, help us target different areas in healthcare where we can make cuts and save that money. Work with us to do that. Okay? But they also included a cool provision, and I passed this by, it is true, that if we work together to make cuts that are above and beyond the target that we had, the difference will go right back into physician salaries and will reduce the 0.5% cut that you guys took. It's kind of a nice incentive. The negotiations guide was a document, was the playbook that I'm discussing. The process was this. We're going to sit down, we're going to try to work it out. If it doesn't work out, we're going to include what we're calling a facilitator. That facilitator is going to sit down with us, we're going to have a lot of talks, and if it breaks down, that facilitator will produce a report that critiques both parties. This will be a private, confidential report. Nobody will have access to it in the public. Then we're going to go to what's called a conciliator. The conciliator will do almost exactly the same thing. We'll meet with both parties, we'll try to come to terms, like find some common ground, and move us forward to a common understanding. This report is a public document. You can find it. It's 7 pages. It's actually worth the read. The government refused to include arbitration in this document. But despite that, the OMA agreed to this process and withdrew the charter challenge. Is everybody clear on that? Okay. Back to the timeline. So the new contract that we signed in 2012 with all the savings in mind expires. 0 realized savings. In fact, we're over budget. So the government says, we got to cut your wages. That was the deal. Huge fallout. Nobody's happy about this. So guess what? We go to the facilitator, no resolution. We go to the conciliator, no resolution. And because they still can, the provincial government imposes unilateral cuts. Now there's a hiatus on discussion. Nobody's back at the table. Well, they have been, and we'll talk about that quickly. But that's how things have gone down over the last 2 years. Okay, where are we now? So they're sitting down again. In fact, they sat down on Tuesday. And when I asked Atul what the ask would be, it would be the addition of a provision for arbitration. And I said, Atul, what is the likelihood that the government will say, yeah, okay, cool, yeah, we agree to that. And he agreed that it would be very minimal. So then I said, well, what's the process then moving forward? Well, the OMA is probably going to issue or continue with a second charter challenge. What does this mean? Well, it means that the OMA thinks that there are some Supreme Court rulings that are in their favor that will likely help in their bid to include arbitration in our document. What does this look like? Probably several months, 2 years of legal challenges and processes before we actually see a result and inclusion of arbitration in our contract. What else has the government hinted at moving forward? They've hinted at a concept that's called reconciliation, which sounds very inclusive and nice word. But what it in fact means is that we're going to cut your wages, and if we don't realize the savings that we want to realize, we're going to see how much over you are, and then we're going to cut that amount from every physician. This has been included because traditionally, when we cut one fee structure in Ontario, physicians just bill the next fee that's a little bit higher. And so despite that fee that's been reduced, we kind of just react and bill different fees that accumulate to either more or the same as it was before. And so the government says, you can do that, but we're just going to claw it back in the end. They've cut all of the CME, and this is important for our colleagues in the community. And for those of you who know Healthcare Connect, they've also eliminated Healthcare Connect. Okay. So here's the summary slide. Health always overspends. We have large debt, and the feds cut transfers. The medical profession has some significant pay differences, and we have colleagues who are already taking some pay cuts. And the Ministry of Health has no money. The docs don't want to give up any money. There's no process for resolution, and the parties will continue to be at odds until there is a real process for resolution. This is the slide where I impart, one slide where I impart my own observations on all of this. Okay. One, I think the government is guilty in that they haven't bargained in good faith. Nods? Okay, good. I'm not going to explain that anymore. No. I think doctors are guilty because we really don't care very much about how we impact healthcare costs as individuals. That's not to say that we don't look into our salaries, but how many people can't get a CD to work and order a repeat CT scan? How many people just send urine cultures off and don't know they cost $20 to $25 every single time? We don't have a good appreciation of the cost that we have as we operate in our theater, and I think that's a big problem. So I'm going to leave you with that. And now is where we get into some questions, some debate. I won't address your name on the mic. We can just talk freely about all of these things. This camera's not on you, camera's only on me. All right. Go ahead.
Another argument you hear on the news is that Ontario doctors have the highest salary in the country. You haven't really mentioned about how we compare to similar positions in the rest of the country. Are we in fact the highest paid positions compared to other places in Canada?
Yeah. So Ontario and Alberta tend to be the highest paid provinces. And specialty specific, I think those probably remain true. Who's on top and who's on the bottom is debatable. Overall, our income is quite good. And if you look at a 2014 report by CAHA, it does say that Ontario physicians are making the most in the country.
One more thing that doesn't seem to be addressed in at least the government, I'm hoping the government is thinking about this, but if you think we have it bad now, give yourself another 10 years and the healthcare costs will really explode.
Right.
How are we planning to be able to meet the healthcare needs if we don't intend to spend anymore? Essentially, even status quo for the next 10 years is going to be completely unacceptable because our healthcare costs are just going to explode.
Yep. So so the comment is that healthcare costs are going to increase over the course of the next few years. I mean, a few things are quoted for that. One is an aging population. If you look at the course of our increased healthcare costs over the last several years, that accounts for some increased healthcare costs, probably about 1 to 2% of overall healthcare costs in I think a 6 or 7% yearly range. That being said, we also see that physician test ordering is a huge driver for healthcare costs. So we do have to make those analyses and introspection on how we're going to do it. What you've isolated, though, is that where is the group that's actually looking to change this over the course of the next 15 years? Who's thinking about 15 years down the line? And I don't think any group can be accused of doing that yet.
Shawn, you mentioned that the term challenges, if they go forward, are going to last potentially years. If this is the case, first, so two aspects of that. One, where is the OMA getting funding for that? Is that all of our dues and going into legal costs for that?
Yep.
And number two is, where do you actually see the cuts going? Is this going to just be a continued slash and go mechanism for the government to go like this last years, or is this something where there is an end in sight?
Well, I think the government, at least yesterday, and 2 days ago, I should say, committed to establishing what they're calling a task force. And essentially, the goal of that task force will be to look at how we spend money in the province. But globally, I would be surprised if that task force didn't come out with focused cut recommendations rather than across-the-board recommendations. I think the government did this because they felt like they went through a long negotiation process and they didn't have the time to really sit down and do focused cuts. They needed early upfront savings. That being said, I would be very surprised if the government as a whole just continued to implement across-the-board cuts. I think they understand that that's probably not the right way to approach healthcare physician spending in the province.
The legal costs go away?
Yep.
Is that us paying for
Yep.
it over the years?
Yep.
So one thing looking at that Facebook group, they talk a lot about like the immediate impact of these cuts.
Mm-hmm.
With doctors saying, if this happens, I'm closing shop.
Right.
What's your take on that? Have you come across numbers that support or refute that?
So I have a pretty critical take on that. I mean, I think if you're operating a clinic with a 2.65 or a 1.3% margin or a 4% margin, you know, it's hard to believe that there isn't some efficiencies that can be done there to increase the potential to operate. The second thing I would critique those individuals for saying is that if you're a fee-for-service clinic, striking clearly doesn't make you any money. So how does that talk to your bottom line? How does that stop your clinic from closing? It just doesn't. Are there clinics that are going to suffer from these cuts? Absolutely. The clear outliers are addiction clinics, methadone clinics, and you're going to probably see a lot of those that just stop operating as they currently are. Overall, do we have an appreciation of kind of what the private financial dealings of individual clinics are around the province and who's really at risk from these cuts? I don't think we do. I think we just have the words of the people who operate them and whether we believe them or not.
One of the other pieces is that there's this balance between accountability and autonomy.
Mm-hmm.
And I think we really have swung way too far the pendulum to the autonomy of physicians. Because we are a publicly funded group that has the ability to only do cataract surgeries because that's, remunerates well, or set up a family doctor's office where we want to practice with no concern about what the needs of the community are.
Right.
And I think until we address that balance, we're not going to get good value.
Yeah, I think that's a good critique. I mean, what other employer do you know that says, yeah, go do whatever you do and bill me whatever you want and I'll pay you, right? And you don't need to fill the gap in that community. You don't need to fit this particular hole. So it's an interesting agreement that we have with the province based on this. And I think there's room for an optimization of that for sure.
One thing that keeps getting floated around is this concept that people are going to leave the province.
Yeah.
And we're being confronted right now with a vast oversupply of specialty trainees.
Right.
Have you encountered anything in your readings here about how that might influence discussions and planning going forward?
I mean, I think in this context, when we're making cuts, there's always going to be people that say, okay, well, we're going to leave. And in fact, most of the critics of those people online have said, well, then fine, leave. Because truthfully, we don't really have a ton of other options. As you pointed out, especially with our specialist colleagues, we're graduating a bunch of highly trained specialist residents who don't have work. So if those specialists want to leave, those jobs will be filled to some degree. That's not in every specialty, and that's not kind of a panacea. And we'd hate to lose physicians. That being said, I think the groups that are more put at risk of this are family physicians based on kind of their non-equal pay structure over the course of the last 10 years. And I do worry about the viability of ongoing independent family medicine practices based on these cuts. And I can't say that there's an oversupply of family medicine residents that are graduating in this country. So I think that's a clear outlier that's not addressed in those groups, and it's starting to be addressed, and we'll see what kind of the media brings out of that. Let's go here. Right.
I look at this and I kind of see this as the beginning of the end. What we have was, quite frankly, we're not allowing the free market to happen. Rightfully so, because you can't.
Right. That's right.
To be a society value. So I always kind of cringe when we have, on one hand, we say as a value, we value healthcare, but then on the other hand, we look at healthcare as a percent cost.
Mm-hmm.
Then you're talking about economic terms, and really it's value terms. So, an economy that has 60% of its funding going to healthcare may not be as unhealthy as we're told. All it's saying is that we value 60% of our dollars.
Right. So what I would say to that, actually, and this is maybe like a little bit of a self-serving pitch, but truthfully, I think unless we measure the quality of the healthcare we're delivering, we have no idea of whether the money we're putting into it is worthwhile. So I think that's a first step, for sure.
So the end of that, too, this is hard to measure, which is why we have to measure it.
Right.
Are we really putting our money in our banks or our bucket?
Right.
The money we put in cancer surgery, is that worth the lives saved versus putting in preventive?
Right. Right, and I think we're going away where we need to understand that there are clear indications for every service that we provide to patients, and I don't think we necessarily have that yet. We have a few more minutes. Let's keep taking comments and questions. Let's go on this side. I've been neglecting this side. Let's start at the front and work our way back.
Just from a historical perspective, a lot of your data was from starting about mid-2000s.
Yeah.
I was in practice for 20 years by then.
Yeah.
And so I can tell you that in the mid-90s, I was working full-time here, and I was program director. I was the only one getting any money for program director.
Sure.
I made $10,000 a year. And for the program director, my total income was under $100,000.
Right.
Fast forward, I'm making much more than that.
Right.
And I'm incorporated.
Right.
Thankfully, my wife makes some money too, so we can play that a little bit.
Of course.
And I'm paying much less tax than I did
Right.
years ago.
Right.
So it's not, I understand that we have to be very mindful of our negotiation and try and get what we can, but we've done very well over the past 20, 30 years. When in the late 90s and the early 2000s, when money started dropping on us, nobody said, hey, should we be getting all that?
No. So that comment is in fact exactly what I wanted to hear, because I fought really hard not to inject that kind of slant on this talk and to present something that was maybe a little bit more middle of the road, but I in fact really feel that way. When you tell me the physicians are going to get almost a 4% cut, and I'm graduating next year, whether my next year's salary is 4% less than it would have been, I'm still making a significant difference, right? So for me, I'm like, oh, if I was retiring and I was planning on that extra 4%, that would be an issue. That being said, I think physician earnings in this province are still actually quite good. And the comment there that's based on, when we were getting more money, we weren't saying, oh, I don't know, should we be making this money? Is an appropriate one. And I think we talked about this just before the talk with a few groups up front. We framed this argument as a patient-centered argument. But nobody framed a patient-centered argument when we made refugee health cuts. Right? I mean, a small group did, but not 11,000 people on Facebook, not the OMA. But suddenly everybody takes a cut and all of a sudden it's a patient-centered argument? That's weird. So anyhow, that's kind of how I see this whole thing. I'll move into some more comments. Yeah, go ahead.
So I'm at the office.
Okay.
First year resident, and my question is, we're looking at these numbers, we're looking at yearly numbers of physicians, but how do we know how many patients or how many services were actually provided for that cost? Are we doing more? Is the average physician seeing more or not than
Right.
2003?
Right, and it's difficult to know because really the only person that has access to that data is the OHIP database, right? So you're billing under a certain physician data number and you can see how many procedures are being done. Globally, I would say that without having seen objective data, and despite the salary increases that I showed you on average, I would surmise physicians are probably seeing more patients than they were previously in several settings, maybe not all. So I think with this task force, what will be interesting is when everybody sits down with the ministry, they're going to have access to this OHIP computer. And this OHIP computer is going to be able to tell us a little bit more about actually how we do healthcare in this province. And it'll be interesting to see what comes out of this task force. And I think the OMA is going to like it because it may absolve them to some degree of having to take the responsibility with specialty differentials. Right here, there's a lot of waving. Yeah.
We're both of the impression here that we see less and less patients
Okay.
here because their acuity of care keeps going up.
Yeah.
It wasn't unheard of for us to see 30, 40 patients by ourselves in urgent care. I don't remember the last time I've done this with our resident. Every time we pick up somebody,
Yeah.
it's not just an ankle sprain.
Agreed.
So you see less and you see higher acuity.
Right. I mean, I think we would have to see how that data washes out in a provincial average. Basically, my point here is that I really haven't seen that data, so we'll have to see. There's a lot of interest hands that are. Let's go at the back first because that's been a while.
So I can't really comment on how patients we've seen kind of long-term going forward.
Right.
What I can comment on is I actually went through the CIHI data.
Yeah.
Said that we were the highest paid in the country.
Right.
And when you go through their actual data on the fees that we are billing based compared to other provinces, our fees aren't higher. So per service that we provide, we're not getting paid more per service.
We're doing more volume?
We have more volume.
Okay.
That's the only way you get to a higher number.
Okay.
And it's interesting to think about, because Peter was saying that, yes, we have had
Mm-hmm.
physician increase in salary and everything else, but back in the day when Peter went to med school, how much did you cost?
Fourth year was $1,000.
So can I say that just on the line here? So the question was raised, how much did medical school cost at the time when one of our more senior colleagues had graduated? And the response was $1,000 in fourth year medicine.
Around the time that we started getting those fee increases,
Mm-hmm.
the time that tuition was deregulated, and I was actually the first year of full tuition deregulation for med school, so I graduated with a whole hell of a lot more debt than those that came before me.
Mm-hmm.
And not because I was jetting off to Cancun, just because I was eating sandwiches, basically. And so this is going to play out for the next generation of people, because while 4% isn't a lot, 4% plus $150,000 worth of debt before you even make a single dollar is going to be a big, big deal.
Yeah, and there's various approaches to how we're going to fund health medicine training in this country. And I assume there will be a task force on that at some point. But truthfully, the 4% difference overall will be a very interesting one to see how that plays out in our ability to pay off our debt. Yes.
Just before we get off, Misty and the government were saying, okay, that's it, we're going to cut everything 6%. You guys are terrible at this stuff. Iteration. I keep telling the residents who come out or the people who are talking about budgeting and things that, this goes up and down, up and down, up and down all the time. Peter and I have been through this many, many times, and the fees go up, fees get cut, fees go up, fees get cut. My advice is always live under your means. Never tell your spouse how much you're really going to earn.
Wow, very personal advice. That's good. Noted. Lowball it, okay. Noted. So this is what I wanted to draw out, actually.
Before, when the government would say, okay, we've got to cut stuff, and we looked at, okay, well, we should cut in this area because these guys have made a 12% increase.
Right.
You know, I'm not always been in the bottom.
Right.
Then the OMA has gone, oh, well, we can't do that because they'll just take us to court, so we're going to cut everybody 6% anyway.
Right.
It's never worked.
No.
It's never been effective no matter who's in charge, right?
Right, and what's remarkable in all of this is that still, despite the fact that you're saying that this has been an ongoing thing for decades even, nobody's really sitting down to try to solve this issue 10 or 15 years down the line. Nobody's committed to a long-term view. And although people might include the fact that elected governments are there for, at minimum 4 years in a majority government, the truth is that I think we're equally as responsible as the government in not kind of looking forward. You don't see the OMA having a task force on the horizon of medicine. And truthfully, you see a lot of independent practitioners, at least in the last year, who've produced national level reports on how we should reform healthcare for costs. The ideas are out there. Nobody's picking them up.
Kind of on that note, did you come across anything of what other countries with similar healthcare systems are doing? Like the NHS in the UK has a fairly similar healthcare system.
Mm-hmm.
Government funding everyone directly, and baby boomer generations.
Yep.
How do they manage these excessive costs?
So the NHS, on every quality indicator that's reported by the Commonwealth Fund, does significantly better than Canada. Their structure on how they negotiate with the government is very different as well. Truthfully, if I've made a fee-to-fee comparison or an income comparison, I did not look internationally. But those are the two things I can tell you that from a quality perspective, they rank higher. And from a negotiation structure, they have a much more kind of task force-based structure where it's not one party lobbying for one thing and another party looking to limit that lobby. Yeah, my assumption was that they probably got paid less, and in fact... Yeah, okay. So most international physicians actually get paid significantly less than we would get paid in Canada, save obviously the United States.
One thing that has been discussed around the Facebook group is
the
fact
Facebook
that
group.
physicians don't get pension
Right.
benefits.
Yep.
Do you think, based on what you've looked at, would it be something that would be financially advantageous for the government to put that on the table?
Well, this is my thing. You know, when you make $350,000 a year, if you can't put away for your retirement, that's your own friggin' problem. Right? Like, I'm sorry, but it's not like you're living on the poverty line and you can't put money away. So that's definitely an issue. Especially with incorporation, right? So your corp can pay you up year after year if you keep a decent amount of money in there at a reduced tax rate. So truthfully, like it's crazy to think that we can't provide our own pensions. If we want the government to provide a pension, we need to take another cut, right? They're not going to do it for free, and they're going to dock part of our salaries. So do you think we're going to want to do that? Probably not. Is it financially advantageous? I don't know. I have no idea, but I don't think it's necessary at all. See a paucity of hands. Okay, I'm done.